Okay, so guys, I have to show you this case. I think this is a very interesting case. Patient had some form of a injury lifting up a heavy object and has now problems in the region of the femoral nerve on the right side. So we did an MR neurography, and when we do that, we can see here when I do the MPR MIP how this looks like. So it was already known he had a disc herniation at the L4, L5 level with potentially compression of L4 nerve root, but it was not really giving the same symptoms for the neurologist. It was not clear, so they sent it for MR neurography. And then we can see here the root is a bit swollen. It's thicker than the left side. The right side is a bit thicker. This is part of the disc herniation, which might still be indenting this a little bit. So you can see there's a bit of a difference here, but it goes further. Like you can see, there's a variant. It's not a symmetrical setup here. We have different thickness. Here's an early split, and then you can see when we go down now what happens to the branches that contribute to the femoral nerve. So here femoral nerve, here femoral nerve. So we follow them here, here, and then you start to see it's getting thick, flat, high signal, much higher than on the other side. So this is a neuropathy of the femoral nerve, and here is the normal signal on the other side. So we have a neuropathy, but also you can see there are multiple splits, or slips rather. There is an accessory, not accessory, but it's just the femoral nerve can sometimes have different variants in terms of the number of nerves, the level of splitting or distribution into different areas. But I think the interesting bit here in this case is there's more than this. So, but why is this? Like, what's this one here? Like, if you look here, there's an additional fiber, potentially nerve. I'm not sure if this has been disrupted here as part of this. But if you look on the T1, what we can see is, especially here, there is a muscle bulge which is missing here. And the femoral nerve here sits exactly in this groove between psoas and iliacus. So this is where the femoral nerve normally passes through. And we can see this here. You can see, so we have the femoral nerve. It's sitting right there at the psoas iliacus edge. And here it's in between, or it's still in this edge, but we have this accessory muscle slip that's sitting on there. It's kind of like splitting the nerve also in these two separate areas here, and even here. So it's kind of like an anatomic variant, which has been described in anatomic papers to predispose for femoral nerve entrapment. But since this was an acute case, I think maybe the fact that this muscle is embedded here completely in this muscle, if the patient was very active and lifting, maybe there was just an acute injury to the nerve, or I'm not sure if this was disrupted. I didn't call this in my report that potentially there is a disruption of the femoral nerve, because I'm not quite sure. I think the resolution doesn't really give me enough information to make this call. But I think this is a very interesting case. So let me go back to the PR. We can make 15 millimeters. Let's see what we can see. So let's pull this back like this, and we can also make it a little bit like this. Oh yeah, you see, it's the third missile alert in, I think, 1 hour. Okay, anyways, so you can see here how nicely we can see the neuropathy of the femoral nerve and how it is normal on the other side. And yeah, so there's some anatomic variation going on with this accessory muscle slip. And we can also go and find these origins here. So you can see these different slips here are not present on the left side. So they are originating from the transverse process of L4 and L5. They come down here. The femoral nerve then runs underneath it rather than on the surface of the muscle. And then based on this, like depending on how you move, you might get kind of like compressed or was compressed with this acute injury. So that's the one finding. The other finding is, if you look here, and you probably have seen this already, there is edema at the gluteus minimus muscle, which is innervated by the superior gluteal nerve, although the gluteus medius, which is innervated by the same muscle, is not affected. So that's a bit strange that only one muscle is affected. Teres minor would, not teres minor, the tensor fasciolate would be another muscle that's affected, but I think we don't have it on this field of view. But so what's causing this? So we're looking at an injury to the superior gluteal nerve anyways, and if we go down here at the sacroiliac joint edge, there's a tiny high signal increase. This is where this is the superior gluteal nerve. And I think this is just a focal partial damage of this nerve here, for whatever the reason might be. I don't know, but yeah, interesting. And yeah, so I think this was a highly interesting case. Anatomic variation, femoral nerve splitting here with an accessory slip. I don't know, potentially disruption of one of these fibers. Maybe I should add this in my report actually, because it looks like it's ending blindly.